Hi, this is Mary Sir from M2 Revenue, and this is the second in a four-part series on increasing revenue through billing for nurse work. This module is on patient education and training performed by nursing staff. Why consider adding education programs? I bet, regardless of what the specialty is, that you can think of at least one thing that you would like to have more time to educate and train your patients on for at least 15 to 30 minutes. And doing that would help the patient because there's increased compliance in face-to-face education versus doing handouts or videos or YouTube links, things like that. It also potentially increases revenue because there is reimbursement for some of this work. I believe that it improves nurse job satisfaction because you're giving the nurses something to research and become an expert on, and the ability to teach, which are all useful things to have on your resume as they grow in their careers and grow in their work for your practice. It also creates a marketing tool to say, hey, I've got an education program on any number of things, and that this is helping the community. I think it also increases clinic efficiency because you do want to try to take the time to do that teaching, and I'm sure it's being done somewhat during clinic, but usually your clinics are really busy and it's not time to do that training. So this can pull that training out into a separate time, maybe when nurses have downtime when you're in surgery or doing something else, so that they can be productive and generating revenue in a time that's quieter for your clinic. And then also there could be a shortage of options in the community. You may not have, obesity programs or asthma programs, things like that they can have training on, and this would be a way to solve that need. Patient education mainly falls into two buckets, and I'll go through each bucket in its entirety. The first is education and training for self-management. In these situations, the patient has a clinical diagnosis, but they need help managing it in their home life and just life in general. So I gave some examples of asthma training, Crohn's training, obesity management, but basically it can be any clinical diagnosis that could support a structured course. So again, think about your specialty, your common diagnoses, and whether it could support a structured course for your clinics. The billing is defined by the number of participants in 30-minute increments, and they have a code set for an individual, they have a code set for 2 to 4 patients, and a code set for 5 to 8 patients. The second bucket is risk reduction and promotion of health. So these patients may not have a clinical diagnosis, and you want to keep it that way by helping them stay healthy. So these classes probably are geared towards pediatrics, geriatrics, primary care, things like that. But any subspecialty can also have these for a patient population that they want to maintain health once they've gotten over their diagnosis. So examples could be maintaining heart health, teen safe sex education, developmental milestones, dietary counseling, safe exercise training, and again, any training that answers common questions in a thorough way that can't be done efficiently by a provider in clinic. Those are the things that you want to create a course for. In this code set, billing is defined by time with separate codes for individual versus group. So the individual is in 15-minute increments and the group is in 30-minute increments. Unlike your self-management codes, however, there is no minimum or range in the group. It can be a group of any number of individuals, and the reimbursement that you will see is per patient in that session. So again, the CPT code range is 99401 to 404 for individual and 99411 to 412 for the group. I spoke in the last slide about reimbursement, and here's just typical reimbursement published by CMS for these services. So an individual patient training, again, doing that for a clinical diagnosis for 16 to 30 minutes is $29. Again, this is CMS. Group training by a nurse for 5 to 8 patients for 16 to 30 minutes is $10.38 per patient. So you can add that up. Preventative risk reduction counseling by a nurse for 8 to 15 minutes is $24.57. And preventative risk reduction counseling by a nurse for 16 to 30 minutes is $7.61 per person. Again, you can add that up because each person will be submitting a separate claim. So what is not considered patient education? Anything that a physician or an APP does and time spent in education and training is not included in this code set. This is just for nurses. So again, when you're thinking about reimbursement codes, it's for nurses. It's not for physicians or APPs. So think about how much you pay a nurse and how they're going to be able to supplement some of their own salary by doing some of these trainings. For your trainings as providers and APPs, you would bill with E&M codes. If you have an individual nurse training patient that doesn't have a standardized curriculum, like somebody needs to learn how to take a medicine or something that doesn't have a curriculum, you would bill that using 99211, which is your typical nurse visit code. And then if you have virtual or telephone education, this was not approved by CMS to be added to the telemedicine reimbursable set, so you would not be able to bill for this in that scenario. Also, patient education by providers who can be enrolled to bill for their own services, like nutritionists, therapists, etc. They usually have their own code set and would not be using these codes. Some general guidelines about this code set: it must have a standardized curriculum that usually some established or recognized healthcare society has blessed. The patient or the family must be actively engaged in the training. It must follow the guidelines for time-based code, so you can't bill for less than 16 minutes for the individual clinical diagnosis and then less than 8 minutes for the risk reduction diagnosis. And then you can perform the training on the same day as another E&M. That's okay, but you may get denied because this training is usually done incident to your prescription or order as a provider. So depending on the state, the name on the claim is going to be yours as the ordering or prescribing provider, not the nurse's. And then if you bill an E&M on the same day, the payer could say, well, if you're the same provider, it's the same code set and you should have used the E&M codes, but you can appeal that with notes as needed. For documentation requirements, we spoke on the last slide about having a prescription or order from the treating provider. That is absolutely necessary and it must be in the patient's record. You should have a handbook or detailed set of instructions for the patient. Again, that's your standard curriculum. You should record the therapist, the nurse's time spent conducting the treatment and the education. And then you should also record the evaluation of the patient's and caregiver's adherence or compliance with the steps outlined in the handbook, either in a subsequent visit with you as the provider or in a subsequent training session. It's important to see how effective these trainings are, and it's also important to see what next steps are needed for that patient. This is just a quick slide to show you that there are other CPT codes out there for other specified types of training. There's one for inhaler education, there's one for dialysis, one for blood pressures, one for alcohol and substance abuse, one for diabetes education and smoking cessation. I'm sure there's others. There certainly are level 3 codes and codes being developed all the time. My advice to you would be just to make sure that you're using the most appropriate code for whatever training you're deciding to do. The next question you may have is, how do you get started? I think it's really important to gauge interest from your patients and nurses by asking if they would like to participate in a structured educational session for your diagnosis or area of risk. I think it's important to research your local payer guidelines. Not all payers cover this service, and the biggest reason why is that a lot of payers are creating their own health and education programs for their subscribers. So it's important to know who would cover the service and what to do in case they don't. In that situation, you might want to consider having an ABN type form for when insurance doesn't cover and the responsibility would shift to the patient. If you notify them ahead of time that their insurance is not going to cover this and that it would be expected to be a self-pay option, they can then be aware and plan accordingly. I would also formulate a reasonable charge so that self-pay is an option for these patients and it would be comparable to other educational services in the community. Next, just think of what courses would benefit your patient population the most. This is the fun part, coming across how you're going to treat and affect the most patients. And then create a curriculum outline that must be approved by all the providers in the practice, because each provider may be seeing the patients that have had this education. And then lastly, schedule a patients via pilot to see how it goes and to see how the nurses feel and how the patients feel. And hopefully it'll be a huge success for your practice. As always, if there are questions, feel free to email me at question@m2revenue.com. Thanks for watching.